On this case, we're going to replace some old PFMs that the patient has on tooth number 8 and 9. You can see they're kind of high value, and we've definitely got some gingival problems as well. And to make this exciting and just to kind of show what we can do, we're going to replace these with some all-ceramic crowns. Specifically, we're going to make Bruxer crowns for teeth number 8 and 9. And you can see on the lingual here where the patient has either worn through or the laboratory has fabricated some metal runways for the patient. And as we get a closer look at the gingiva here, you can see that we definitely have some issues. It's swollen, it's edematous, and it looks like it's just ready to bleed. But first things first, need to take the shade before the teeth become dehydrated and start to appear higher in value than they really are. So we're going to the two adjacent teeth, the lateral incisors, and I'm getting a 2M1 for my 3D Master Shade. As you know, I love the 3D Master Shade Guide because it's so much easier to match to natural teeth. As you've heard me say before, it's laid out logically and scientifically and very easy to use. This is the linear guide. It's just 2 steps to get to that shade. So here are the 6 different shade guide families here, and it's already told us that the number 2 shade value is the one that we're looking for as I hold it up to these teeth. And you can see that it looks pretty nice. 3 definitely looks to be too low in value in shade family 1. Looks to be a little too light, but certainly closer than 3 is. And there's the 2M1 shade tab right in the middle. I've got the 1M1 on one side and the 0Ms over on the other side, just to kind of give you an indication of what we're talking about. But as you look at the 1M1 and the 2M1, I think the 2M1 is more correct. That's what the Easy Shade Compact told me was a more correct shade in the spot where I happened to put the tip of it. But the 1M1 is kind of in the ballpark as well. So I'm going to hold both of those here next to that tooth, the 1M1 and the 2M1, and take a photograph. My assistant will take a picture. We'll send it to the technician. That's going to help ensure that we get the best shade. That is a really important step here in terms of making sure that these 2 crowns on 8 and 9 are going to match 7 and 10. You've got to take a picture with that shade tab in place. Even though 2M1 might be the closest shade and 1M1's relatively close as well, they need to see those shade tabs next to those other teeth. And boy, look at that. Look at this. I told you the gingiva didn't look healthy. What do you think when you put topical anesthetic on gingiva and it starts to bleed? And this is really just from the tip of that brush kind of bumping up against the gingiva. So we've got some really inflamed edematous tissue here. These teeth have both been endodontically treated. So rather than give this patient 2 infiltrations, which will be somewhat painful underneath her nose, probably the least comfortable place to get an injection, I'm using my STA device from Milestone Scientific just to get some soft tissue anesthesia for the cord packing and the crown removal around these 2 teeth. So there's really no need for me to knock her lip out and get her nose numb and go through all that with a typical infiltration when the teeth have been endodontically treated. So I just go into the facial sulcus at the midpoint of the tooth, and I'm going to give about a quarter carpule on both of these teeth. You can see how the blanching actually moves interproximal to the 2 papilla, and it's been my experience that when I use Septicane in the STA system like this on anterior teeth, that I do get enough bleed through of the Septicane onto the palatal tissue, onto the lingual, where I don't have to give additional anesthesia to pack either of the 2 cords on the lingual. So we start to cut these crowns off so we can see what's going on underneath. You know, part of my thought was maybe this is an allergy to base metals, but as I cut through, it doesn't seem like it because I can see that these are in fact CapTech crowns, and I've loved and used CapTech for many, many years as an aesthetic PFM on anterior cases just like this because of the fact that the CapTech metal actually is beneficial to the gingival tissues. For that to happen, you have to leave a metal collar essentially underneath the gingiva to take advantage of the antibacterial properties of the CapTech metal, and that was not done in this case. It was just a porcelain margin, but still, it's not like if you cover the CapTech, you're going to cause anything bad to happen. You're just not going to get the good anti-plaque effects of the CapTech. So it's a little hard to say what was going on here, whether it was an open margin or if it was grossly over-contoured or there was cement left underneath there. It's really hard to tell about. The only thing we can conclude is that it was not probably a base metal reaction because we had the 22 carat CapTech coping underneath these crowns. So it certainly wasn't the metal that was causing this issue. You could see they on the posterior now that we know these are CapTech, that the laboratory did probably put those metal islands in on the lingual on their own, because a CapTech crown, obviously, if you wore through it on the lingual, you would get right down to that soft CapTech coping, and if you were able to wear through it, and it would fall apart at that point. So I'm just going in and probing, sounding down to the bone here to making sure we've got more than 3 millimeters, so I can go in and remove a little of this tissue without causing any kind of biologic width invasion. So as I go around and see that I'm okay to take off, half a millimeter or a millimeter of tissue, whatever I need to do, I'm going to go in with my diode laser, and I want to just get this unhealthy tissue out of here. Again, when I take a little topical anesthetic and a micro brush and I just rub it up against the tissue to get some anesthesia there, and it starts to bleed all of a sudden, you can tell that we have an issue. It's one thing if you snap floss in between teeth, obviously, and it starts bleeding, but just to put a little topical in a little micro brush and to have the tissue start bleeding that much, there's something going on. And I want to recontour this tissue anyway, and I just want to get rid of that super unhealthy tissue, hopefully get a nice set of temps on that's going to let this heal a little bit better. And then we'll come in next time and finish off the preps and take our impression then. This has been one of the things that I've learned in 20 years of doing dentistry, is that you can't always take the impression even though you have the time to take it that day. Even though you say, oh, shoot, we've got, a whole hour and a half blocked off or something like that. You're compromising this case, in my mind, to try to take this impression today. It's very difficult to get a clean, dry environment to be able to do that, for one thing. And it just seems like the chances of us having a really accurate impression and some really accurate crowns, it goes down the drain. It's just really difficult to pull all of that off. So I'm going to clean off some excess cement at this point, and I'm just going to drop my margins down a little bit to the area right where the free margin of the gingiva is right now. And of course, these are endodontically treated teeth, so I can turn off the air and water if I want to, which I typically do, but I can run it in the handpiece a little bit faster if I want to, just because I don't have to worry about frying a pulp. You've seen me do this all the time on vital teeth as well, where I turn off the water. But I do leave the air on, and I do turn the speed down to about 3,000 RPM so I don't generate a lot of frictional heat. But this is really where you get to see what you're doing at the margin. You get a good idea of how your margin's shaping up, how much you've reduced, how smooth it is. I'm not going to worry about any of that smoothing right now on this appointment. I'm just going in and cleaning off old cement, dropping my margin down a little bit to the new gingival level, because I do still want to have a slightly subgingival margin. Again, I know the metal wasn't the issue because it was a CapTech crown, but we are going to do an all ceramic crown, and I do want to have this facial margin just slightly subgingival, and we do that, of course, with the two-chord technique and without having to take a burr subgingival at any point. So really, this appointment has just become doing the majority of the prep work, just getting the most of the tooth shaped, getting the margin dropped, getting everything where I want it, getting the incisal reduction correct, and then making the temps. And so really, next time, all we want to have to worry about is taking off the temporaries, and hopefully the tissue looks nice, and then we can go in and do what we need to do to get our final impressions and move on at that point. So I've got some biotemps that I've ordered from the laboratory. Teeth number 8 and 9 are splinted together. If we did these as individual temps, obviously much better chance they're falling off. You can see me kind of pushing it very gingerly into place, not wanting to push it on too far and affect the tissue too much. I just have the patient bite together to make sure it's down all the way, but I was trying to basically make sure that I didn't jam a lot of material and then didn't trim it against the tissue itself. So we just put them in, pump them in a couple of times to make sure it's going to go into place and not lock down. Just relined these with Luxatemp, and then we're going to go in and do a little shaping on these. The shaping of the embrasures on these biotemps, especially in the anterior, is really important because we want to give a nice smooth surface here, and we even put a little glaze on it. We use a little Luxa glaze at the same time to get a nice smooth sealed surface as best as we can, so we have an area where the tissue can kind of heal around it. So if anything, we want to over trim these embrasures just a little bit. In other words, the dreaded black triangle that we always try to avoid when we're putting in permanent restorations, it's okay to have those black triangles with the temporary end. And we tell the patient, because we've left this little space for you, if it happens, then you can rinse back and forth with this dental herb company tooth and gum tonic without having to go in there and floss it. And that's going to make sure the gums stay healthy. So if we do have black triangles, we tell them it's in order to keep them from having to floss, and so their gingiva will be healthy and there won't be any black triangles in the final result. So here we are at the next appointment. It's been 2 weeks, and I'm going to go ahead and take my pair of forceps and wiggle off the biotemps. Tissue looks a little better until I take the biotemps off and I can see that, boy, I just left that margin a little bit short. And you can just see some fingers of epithelial tissue over on number 9 that appeared to have crept underneath there just a little bit. So I'll see if I can clean this off with a little Viscostat Clear. This is the clear version of basically the regular Viscostat, the brown one that we use in the posterior. And we use it here so we don't get any deposition of any kind of color on the teeth when it reacts with the retraction cord that we're going to use later. So the Viscostat Clear is a great idea for a product to use in the anterior region where you don't want to discolor gingiva, because it does tend to react with retraction cords, some with epinephrine, some without. Again, I have the diode laser, just kind of holding it over the tissue a little bit, trying to just stop any bleeding before it starts. A little extra tag here that I'm going to get rid of that was just kind of hanging around there, but the tissue definitely is looking better than it did last time. It still has a little bit of healing to go, but it's a funny thing. You take off crowns that don't fit very well and put on some temporaries, and it's a step in the right direction, but the gingiva is probably never going to heal completely until you have some permanent crowns in place that have really smooth surfaces and fit better than the temporaries do. So the temporaries are a nice stepping stone to get to healthy gingiva, but probably not going to get super healthy until the permanent ones are put into place. So the double zero cord is flossed into place, and I'm just putting that in around teeth number 8 and 9. I'm encouraged to see that I don't have any bleeding as I'm doing this and putting those into place, and that cord is going to stay in for the entire procedure today. That's the one that's going to guarantee that I don't have any bleeding. It provides the vertical retraction, so I know where to put my margins, although we've done most of the preparation already, so it's not quite necessary. And this is the 2E Ultra Pack cord going on top of that one. This cord will stay in place for about 8 to 10 minutes. As soon as I get close to having the two ends overlap, I just snip that off, and I leave a little tag hanging out, as you see here. On the double zero cord, the first one that goes in, I do not leave a tag, and they do not overlap at all. I want that all the way down. And now I'm packing the 2E cord on tooth number 8. And it helps you visualize your margin. You can also see that the tissue is, in fact, doing a lot better. Whereas the first time I saw the patient, when I brushed some topical anesthetic with a brush against her gingiva, they started to bleed. Now I'm, pushing somewhat vigorously this size 2 cord. It's a hollow cord, but I'm pushing it down, and we're not getting any bleeding. So we've definitely had some healing, and the gingiva's definitely gone in the right direction. And so now I've got my 856.025 burr out with the cords in, just cleaning up what I can see from the margins that I couldn't see last time because I didn't have the 2 cords in place. And again, it always holds true that the more reduction that you can give the technician, the better the chance that they're going to be able to give you a nicer result. And so at the very end here, we're going to smooth down and get rid of any caries and old buildups. And the 856.025F, this is our red stripe burr being used here. And we're using the red stripe burr to smooth everything off. The days of leaving prep surfaces really rough for micromechanical retention are essentially over, unless you're still using Flex or perhaps Duralon. Today we get natural bond strengths with our resin-reinforced glass ionomers or our self-etching resin cements. I mean, if you've taken off any crowns you've cemented recently with these cements, it is plenty of bond strength, of natural bond strength to the dentin itself. So smoothing everything off just leads to a better impression and an easier time for your technician to identify your finish line and where to put the margins. Once we finish that, we take 2 of our anatomic compra caps from Coltine and put those in place. Always a little bit hard to have the patient close down on these compared to in the posterior. And you can see, again, the wide open sulcus there on the mesial that we get when we have an opportunity to use this 2-chord technique. And again, look at that sulcus there. I mean, I'm going over it pretty quickly and filling it up. Don't blink or you'll miss it. But just a huge sulcus. And it doesn't matter if we're taking a digital impression or a polyvinyl impression. This 2-chord technique just gives us so much room to be able to get a great impression. And we probably could have used a double arch tray here, like a clinician's choice anterior tray, but we're going to use a paletless tray, basically a lower metal perforated tray to take this upper impression without a pallet in it. And I don't know if you saw it real quick, but the bottom chords are still in place, and they'll stay in place as long as they can stay there. Little bite registration, little capture on teeth number 8 and 9. That's the only place we need the bite registration, and then the cords are going to get taken out before the temporary gets put back on again. 2 weeks later, gingiva's looking even better at this appointment with the temps than it did the first time. The temp might have been a little over contoured on the mesial of 9 as I look at where it might have pushed on there just a little bit, and we've had an opportunity to try the crowns in. We wanted to go with all ceramic crowns, and so we went with Bruxer crowns. We did this partly because I wanted you to see how nice Bruxer can look, and partly because we were just challenging ourselves a little bit with the shades as well, and wanted to get a good shade and wanted to do it with the Bruxer too. I'm not saying that if you're doing crowns on 8 and 9, you should. Bruxer does not have to be your first choice. If you chose Emax, I would applaud you and say well done, well chosen, well prescribed. This, I just want to show you what we can do with zirconia that doesn't have any porcelain on it. You know, pretty soon, this may become my material of choice in the anterior. It's a little easier for me to make it my material of choice in the anterior because since I practice within Glidewell Laboratories, I have technicians who can come over and do any custom staining that we may or may not need. I feel pretty confident that using the shade guide as you saw us use it and taking digital pictures of the shade guide and sending it to them, you know, really I feel like we've got a pretty good recipe dialed in for how to be able to get some pretty nice shades, and it certainly helps that the technicians are in the building. So it's probably a little bit easier for me, and but you're starting to see that Bruxer can be used in the anterior. In fact, I just looked at some numbers the other day. Bruxer is now 10%. 10% of the Bruxer crowns that we fabricate are in the anterior regions of the mouth, which is up from 0, which is where it was back in 2009 when we launched it. Again, when I clean the cement off, I cement these with a resin-reinforced glass ionomer. That's 3M SB's Reliax Luting Plus. And as I cleaned it, got a little bit of irritation on the gingiva again, so some Viscostat Clear to stop the bleeding. And there they are, the Bruxer crowns on teeth number 8 and 9. And again, there's no porcelain on those crowns. That's solid zirconia and is extremely strong. And unlike porcelain, really won't chip on incisal edges up here in the anterior and has no metal in it in case she was having metal. You can see the flat facial profiles on 8 and 9 too. That's part of the CAD-CAM story. That's the fact that these crowns are now being milled by a machine instead of a technician, and so we can dial in whatever anatomy we want for these crowns. And it's because I did happen to reduce those teeth enough as well. That's part of the story. You know, as dentists, we have to give the technicians enough room to be able to mill restorations like this. So great looking result for 2 Bruxer crowns on teeth number 8 and 9.